Right now, I will be talking about drugs that are used for cardiac arrhythmias. Here you have a photo of your heart. Heart has the walls of the heart will have myocytes, the muscle cells, and all of these green lines that you see. This is the conduction system. These are also made of cells only. In the conduction system, you have SA node, AV node, Purkinje fibers, blah blah blah. All of these can generate their own current without need of anything else. They have this thing called auto-rhythmicity. Auto by itself, rhythmicity. A rhythm will be generated by themselves. They have very special type of ion channels that I will come back to later. For example, if you have a nerve cell that will not automatically generate an action potential. No, something has another neuron will have to come and transmit the action potential. It cannot generate one by itself whenever it wants. It has some stimuli required, but your heart does not require a stimuli. This is important to note. SA node, AV node, Purkinje, whatever, they will not, all of them will not require a stimuli to generate an action potential and to transmit current. But in your heart, physiologically speaking, you will see that the SA node generates an action potential and everything else required will just transmit it. There will be some delays because of some properties in the Purkinje fibers, some properties in the AV node, some anatomical reasons are also there as to why there is an AV nodal delay between the transmission. I will discuss it later. Why? Exact reason I will discuss later. Right now, you have to remember that AV nodal delay is there and SA node is the boss. Now, you may ask if the AV node, Purkinje, everything else are also autorhythmic, then why SA node's rhythm we are considering physiologically, why that dominates? Answer, because it dominates only. SA node, the rate at which it fires, before the AV, Purkinje, whatever can decide ki, I also want my own rhythm. Before that only SA node will set the rhythm and they will just go along with it and they will just transmit the action potential downstream. So from these conduction systems, they will go into the heart myocytes. This is the action potential of the nodal system, SA node, this one, and this is for the cardiac myocyte. Now let us start with the uh, action potential. First, I will discuss the myocyte, and then I will discuss your SA node. Now, say in the heart, in the muscle, in the myocyte, if it beats on its own, it is not possible. All of this will not beat on its own. An impulse will have to come from here to the myocyte for the heart to beat. This, there is no auto rhythmicity here. This is dependent on this. There is functional anatomy. Both are linked. That discussion, it is not needed right now. But you have to remember that this is not auto rhythmic. Now, there is a resting potential. Nothing is happening to the cell. Something happens from here. Some potassium channels which are being pushed into, or some sodium ions that are being pushed into the myocyte from adjacent. Some current is traveling in the form of ions. It will reach the myocyte and it will cause the opening of voltage gated sodium channels, NAV, your normal voltage gated sodium channels, 1.6, 2.6, whatever that we have been talking about since a long time. Those will open. If they open, the sodium will come inside along the concentration gradient. All of these things, all of these changes are along their concentration gradients only. Hmm? If the channels open along the concentration gradients, your things will come. But if that happens, then your gradient will be lost after one action potential. Then what? There you will have something called the inward rectifier potassium channels. These in your normal cellular metabolism, these have to be activated after every action potential so that whatever ions that came inside, whatever ions that went outside, Your heart has to be ready for another thing, no? So this has to be reversed, no? Like this. So your inward rectifying potassium channels are important. You will see this link to SCR also if you read sulfonylurea, anti-diabetes drugs, secretogogues also they are called. But this is not the time to discuss that. Now, something happened. Your potassium is both going out, coming in. There is a very nice balance. Your membrane is resting. Impulse comes, sodium will come out. Upstroke is there. Upstroke of action potential in the myocyte is because of sodium. Through what? Voltage gated sodium channels. Now, once it reaches its peak, this is called phase 1. In phase 2, there is a transient potassium current where the potassium tries to go out. Sodium comes in because of the changes in the membrane potential. Your potassium channels will open up. Potassium will now try to go out because there is too much potassium inside the cell and no potassium in the blood. 3.5 to 5 is your normal. Your potassium is already inside your cell always. So if the sodium comes inside, too much positive charge, potassium will now go outside. To combat that, if the potassium is going outside, if you have read membrane physiology, you will know that this graph will go down. The membrane potential will go down if the potassium is going out. But as this happens, your calcium will start coming inside. This transient potassium current will trigger L-type calcium channels to open up. So this will cause calcium is wanting to take the graph here. Potassium is wanting to take the graph here. So the graph will just stay parallel like this. So calcium is trying to come inside and take the graph here. Potassium is trying to go outside and take the graph here. You will get a parallel line. Now, once the calcium movement has occurred, now the potassium can freely go outside and take it back here. Now you might say that the potassium should keep going outside, but it does not happen like that because there is no saving mechanism or whatever that I will discuss in a few minutes here. So how is it not just going down? How is it coming flat? Because of activation of inward rectifier potassium channels. It is there in its name only, inward rectifying. So potassium was going out here, out of the cell. Here potassium was going out. Inward rectifying will open. Potassium will come in. So membrane, nothing will happen now. That's how you will get this. Now here and here it was different potassium current. Here and here the potassium that goes out, it goes out through a specific potassium channel called delayed rectifier potassium channels. The name is important. That is the name given. Now there are subtypes of this also. Not very important, but if some sadist is sitting a question paper, they will ask. Rapid component you have, slow component you have, ultra rapid component you have, which is only seen in the atria, not in the ventricles. But this is not very much important for you to remember. Just remember that there is a rapid and slow component of the delayed rectifier potassium channels. Okay. Now let's come to the SA nodes action potential. Here, this is autorhythmic, so bear with me. It is a continuous cycle. If I start from here, if I start from here, if I start from here, I have to come back here while I am telling you the story. So, for whatever reason, your sodium is starting to come inside the cell. There will be depolarization, raise in the membrane potential. Then the actual upstroke of the action potential will happen because of calcium. Here it was because of sodium in the myocyte, but in the node it will be because of calcium. This change depolarization will trigger opening of this L-type channel, which will cause the upstroke of the action potential. Then same story because of all the positive charge, the potassium will want to go out. This is your normal potassium current, no weird names. Now, this sodium is not your NAV, not your beloved lignocaine wala NAV, not your beloved membrane physiology nerve NAV. This is a very special type of channel called HCN channel, where the current, that is a originated because of the sodium is called your funny current. Why is it funny, you ask? Because normally, what do we say happens when depolarization occurs? If there is depolarization, then your channel will open. Normally, this is what we say in nerve membrane physiology. We say if there is depolarization, your uh, ion channel will open. But this acts funnily in the fact that if there is hyperpolarization, like the hyperpolarization happening because of the potassium current, this will open instead of closing. So once there is hyperpolarization, immediately the sodium channel will open. Sodium channel will open, then the calcium will open. Then because of all that positive current, the potassium will try to go out. Hyperpolarization happens and sodium will open. This goes on and on and on. That's why we call it as autorhythmic. So remember the Hessian channel, you will have I vibrate in class 0. And arithmetic not very important for you to remember. I found that classification as class 0 in StatPulse if you want to go and check out. So you, this is very important to remember and to understand because now I will be starting your drugs. Before I do that, let me talk about this is your sodium channel. Look at the states at which your sodium channel is there. Now, this is a very important concept. I, if I were to ever write a physiology textbook, I would write the sentence, it is because of the difference in the speed at which the gates of an ion channel is open that we function. How? Let me justify. The sodium channel has two types of gates, one inside the cell, one outside the cell. These are the activation and inactivation gates. Now, activation gate will activate or open upon depolarization. Inactivation gate will close upon depolarization. So, where is the sodium channel? So here some depolarization happened, so sodium channel is opening. Your normal sodium channel. But when that happens, activation gate will rapidly open. But your inactivation gate will not rapidly close. It will close slowly. Speed of activation gate is greater than the speed of inactivation gate. I will justify my statement later. For now, you have to remember this. So now sodium cannot go because here a block is there. Here the sodium can easily go. Here the sodium cannot go because the block is there. Resting is like this, inactivated is like this, activated is like this. Some drugs will preferentially bind to some of the states, which will be discussed later. Broadly classifying the drugs, they are class 1, 2, 3, 4. One is your sodium channel blockers. Two is your sympatholytics, beta blockers. And then class 3 is drugs that prolong your action potential duration, mostly by blocking IKR. What was IKR? A rapid component of delayed rectifying potassium channels. Class 4 are calcium channel blockers in regions where upstroke is calcium dependent. Where the upstroke is calcium dependent in the nodes. Class 4, we will see. Now, look at the class 1 drugs. This is also sub-classified as A, B, and C. If you want to pause, you can pause and read this table. Is one trick that I use is plus minus 0. Now the 0 comes here, plus minus. APD is prolonged in 1A, decreased in 1B, and nothing happens in 1C. Kinetics of sodium channel blockade or the speed at which they leave or dissociate. 1A, nothing, normal kinetics. 1B, they leave very fastly. 1C, they leave very slowly. Now, 1A, you have drugs procainamide, quinidine. Quinidine is very much similar to procainamide in mechanism of action. Now, let me talk about mechanism of action of your class 1 drugs. All will have the same mechanism only. Now, This will act on the sodium channel blockers. So if the sodium channel is blocked, your sodium channel is there in the myocyte. So if it is blocked, it will slow down the upstroke of the action potential where in the myocyte. It will slow the conduction. Now if you tell me that here in the nodes the calcium is there, calcium L type channels, there is no NAV and class 1 drugs are supposed to block the NAV. But I have made a table here where you can see research has shown that the upstroke of action potential in the Purkinje cells is because of sodium channels, which are your normal NAD. But these are also autorhythmic. Speed is slow, which is also one of the reasons why from the SA to AV to Purkinje if it is going, here there will be slowing, here also there will be slowing because here the current is fast, here the current will slow down. Another reason. Now, where were we? Now, the action potential is prolonged plus there's some partial potassium blockade also. Don't worry, not frequently used because of these reasons. You can see the second or third line for ventricular arrhythmias after MI. This is usage, but what all can it do? Most atrial and ventricular arrhythmias can be blocked. Atria and ventricles are chambers of the heart. Heart will have myocyte, not conduction system, the thing that we're talking about right now. If you want to divide the heart into two things, conduction system is different, myocytes are different. If the problem is arising in your myocytes, if there is a circus current inside your atria, or if there is a circus current in your ventricle, or if there is an ectopic foci, which is radiating out your action potentials, if they are in the atria and ventricle, which is happening because of problems with the myocyte after some MI has happened, then it can work in both atria and ventricle. How? This is there in both atria and ventricle. Remember like that. Now, lidocaine 1B, lignocaine also it is called. It blocks activated and inactivated sodium channels. Here it is resting, then it is activated, then it is inactivated, then again it is resting. So activated and inactivated it blocks. Now, if it is blocking the inactivated portion, the drug is effective in places with large time consuming inactive states in long action potentials like the ventricular system and Purkinje systems. But you have to remember the ventricular point importantly. The ventricles are big compared to the atria. Even in the EKG, you have this small P wave and then the big Q wave is there. Ventricles, they will have bigger action potentials. So they will have most, say for example, in the atria also you had, it will be relatively smaller now, your action potential. So this region is bigger, more time for inactivated. The lidocaine will bind to more inactivated state. So it is very good for ventricular use. So drug of choice for termination of ventricular tachycardia and prevention of ventricular fibrillation after you resuscitate an MI patient. Once not an important. Class 2 sympatholytics also not that important. Now come to class 3 amiodarone. Class 3 they prolong the action potential duration by blocking the potassium channels. Which potassium? Delayed rectifier potassium channels. Which component? A rapid component. It is given oral and IV. It is used for serious ventricular arrhythmias and AFib low dose. I will come to that later. IKR is blocked. If you use the drug chronically, IKS is also blocked. Not important. Remember KR. A rapid component, the rapid of delayed. Now, your amiodarone has sodium channel blocker property. It has your sympatholytic property. It has class 4 calcium blocking property also. Majority potassium channel property. Because of the broad spectrum of actions, it is probably responsible for less incidence of torsades. Despite significant QT prolongation, all class 3 drugs cause QT prolongation. Why? I will tell you later. Here you can see, here is where the potassium channel delayed rectifier is there. Here it will act. Where is this myocyte? So serious ventricular arrhythmias, and in low dose it can be used in AFib also. So fibrillation of atria, arrhythmias in ventricle. We are not talking about arrhythmias of nodes of these two. Now, class 4. Here, nodes have come. It is a calcium channel blocker in a region where upstroke is calcium dependent. There is upstroke calcium dependent in your SC and AV node. So they will act for arrhythmias originating from SC and AV node. If you look at both the nodes, if the SA node action is decreased, there will also, because of the calcium channel property, blocking property in elsewhere in the body, there will be some hypertension, which may increase your SA rate also. So we want it to decrease, but it is decreasing also. So SA not very significant. Focus on AV. AV is blocked. Now, atria is there, ventricle is there, AV node is there. If the AV node is blocked, all the arrhythmias occurring because of this level will be blocked, which are your supraventricular, above the ventricle originating tachycardias, which pass through the AV, or because of some problem in the AV node, these supraventricular tachycardias can be controlled. You can control the ventricular rate in if the arrhythmia is originating in the atria or the AV node, if they are supraventricular above the ventricle, the ventricular rate can be controlled through the AV's action. Okay, very good. Now, let's come to adenosine. It is not 0, 1, 2, 3, 4. It is different. It is drug of choice for PSVT, paroxysmal supraventricular tachycardias. You have AVNRTs, you have AVRTs, AV node reentry tachycardias, and atrioventricular reentry tachycardias. Basically, there will be circus currents or reentry currents, not ectopic. If from your myocyte somewhere it starts randomly giving action potentials, it is ectopic. If somewhere in the myocyte or in the AV there is some reentrant current, sorry, then that is a reentry. So PSVT can be atrioventral AV node reentry. In the AV node, there is some reentry current, and then now it is shooting like that. Now here it is drugs of choice. Why you may ask? Let me tell you. There is, because of adenosine, there is activation of the inward rectifying potassium channels. Here this will activate. So this potassium that was going out, it will fastly take in. So it will shorten your action potential by a bit, and whatever supraventricular tachycardia is there, it will come and affect downstream only. The ventricle it will affect. Now this too much, this is happening too much. So they're like, no, 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 don't go out, you come in. So whatever action potentials that kept happening like this at these places, the drug is saying, no, no, you come out fast. So this will shorten, and overall it will try to stop the hyperactivity. And this also blocks calcium current at the SA node and AV node. Now, SA PSVTs originating in SA? No, they are originating in the AV node. So forget about SA node for now. Also, clinically important that when given as a bolus dose, it inhibits AV. SA not that much. So if here there is a re-entry or something and it is shooting into the ventricle, it will control the ventricle by blocking here, and it will slow down by blocking here if the problem is in AV, like that. Yep. Thank you. Acha, and for trying to justify that statement that I made, imagine if there was depolarization this opened very fastly and this closed very fastly. How will the ions come in or out? There has to be some time, no? That is why this is very fast and this is slowly. So this is this is opening like this and this is closing like this. So here your ions can pass. If the difference in speed was not there, ions could not have made their way and no nerves, no cells, no action potentials. How would the body then function?